I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Friends. Welcome to our first episode of Faisel Friends. We're switching the time from Fridays at noon to 8 p.m. Eastern now on Thursday evening. We're here because everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is the dollars and cents of universal health care. Robert.
Hey.
Good to see you.
Well, it's a new day, it's a new show, it's a new time. We'll just see how we interact at night. I feel like you're going to be peppier than usual. I'm usually a morning kind of person, so we'll see how this goes.
Well, I'm so thrilled to have one of our associate chief medical officers from Ohio, Dr. Rusty Harrington, joining us today. Hey, Rusty.
Hey, Faisel. Hey, Robert.
Hey, Rusty.
We decided to change, I think it was just on Monday, to change from Fridays at noon to Thursday evenings at 8 p.m. Eastern. And I was like, Rusty, I first told him Friday at noon. He had meetings, and thank you so much for being nimble and flexible to be able to switch to this evening time.
Yeah, I wouldn't miss it. This is a great conversation, so thanks for having me. I can't wait to
Oh, great. And Dr. Dan. Hey, Dr. Dan.
Hey, Faisel. How are you?
I'm good. I'm good.
Great conversation. Looking forward for good questions too.
I've been getting messages recently, people saying that, hey, I don't agree with your tagline. Healthcare is not a right; it's a privilege, and I struggle with how to engage with people to explain to them that we're already paying way too much for healthcare that is taking the health of the country in the wrong direction. The system is not aligned to where the patients and the people's health benefits. So, for example, if it's a slow second quarter for most, or the third quarter for the hospitals, they're looking forward to a bad flu season. When they're saying, "Oh, hopefully we can make up for this slow quarter with a bad flu season," because the patients will be getting sick and the hospital will get full. And that really does not represent healthcare. That represents the worst. It represents sick care. And so we're already paying far too much. It makes much more financial sense to invest in primary care to allow everyone to have access to a doctor for all the little things.
Yeah, Faisel, I think people have gotten caught up in this socialist rhetoric about how universal health care is something that's anti-American. And I don't think any of us are here today to promote a particular policy. I don't think we're here to say, Medicare for all or Medicaid for all or public option or, complete new revamp of a government-sponsored health coverage. I mean, I don't think we're here to promote that. And correct me if I'm wrong. But what we are here to promote is the idea that if you extend coverage to the entire population and give them access to high quality primary care, what you're able to do is prevent them from seeking care at the emergency department. And that's where you get so much more cost, which contributes to the overall healthcare cost in the country. It's also not the best place for people to get taken care of for long-term chronic conditions. And so what we're trying to say here is that it makes financial sense to put the healthcare dollars universally in the right places. And I think that's really where the three of us might all agree on what should actually be done. There's plenty of policies that can be enacted to make that happen. But we think one of them, something needs to be done to provide that extra access and coverage to effective primary care And I know we all are big believers in the effective full risk primary care. So I think that's my take on today.
You know, here's my issue. When I think about, we're already paying for other people's care anyway, and so it really, having this conversation is kind of like, it's almost circular at times, where our rates are so high. Insurance, companies are charging so much because they're trying to make up the difference for a lot of people who do not pay or self-pay. How unfair is that for somebody who pays cash is going to pay the full amount compared to someone who has an insurance company that has a contract that's going to have a different rate? Also, different hospitals have different costs for the same procedure. So really, the conversation is, I think there's a lot of frustration with healthcare. The question is, let's lay it out on the table, and let's not label it as socialized. Let's not label it as capitalist. Here's the issue: are we getting our money's worth as a country? That's the question. Are we?
Exactly.
I think that's a great way to put it. And, Faisel and I were talking earlier this week. We're like, do we want to try and make a moral argument? I think he and I agree. I don't know about you, Dr. Harrington, but, we agree that it is the right thing to do to take care of people. But we think the most universal argument that we can get everybody on board with is this idea that is a good place to put dollars. It's a good place to invest in the health of the population, which improves productivity. So you have less absenteeism at work. You have people who are able to actually seek jobs. You have people that are able to grow the economy, which actually helps everybody out at the end of the day. And so it's an investment, and health as an investment is something that's really difficult to communicate. And I don't think it's something that is well understood in the general population. So I'd love to hear from you guys, because you're physicians. What benefits do your patients get? Like, if somebody's really not in good health and then they start to come under your care and then you get them into better health, what other external benefits do they get besides just health? I'd be curious your thoughts on that.
I'll take that to start with, and I'll pass it to Faisel. I will tell you, one from just feeling like I've done a good job. This is why I went into medicine, was to help people. I kind of went in what I thought were noble reasons. It's how better can you get to know somebody than get to, you close the door, you get to know them psychologically, spiritually, physically. They're going to let down a lot of barriers. And over time, we develop a relationship that we have a more intimate relationship with our patients than sometimes they can tell anybody else. So for me, from a personal perspective, it's rewarding to get to know somebody and help them out. But even like Faisel, we work in seniors, and I have found that some of my patients who have we can admit there's disparities in care. Not everybody has access to care. When we start to balance that out, and patients that come in with multiple chronic conditions, like 5 chronic conditions, uncontrolled diabetes, maybe a history of smoking, heart disease, all of a sudden, you think somebody has told them, you need to quit smoking, you need to get your diabetes under control, and come up with a plan. But they've gone to the ER. It's sort of this disease treatment, this constant wheel of treat whatever the problem is, turf them, and then get them back out to wherever. And then they'll just show back up in the ER, or maybe their doctor. When a patient tells me, thank you for spending time and explaining this to me, nobody's ever sat down and helped me get my diabetes under control. I mean, that for a senior, for somebody 65 to 70, that's amazing that we've reached this point. And it's never too late to prevent. So that's what is really amazing. And you still give quality life to patients who, have been poorly controlled their whole lives, but have lacked the education. I'm just going to follow this, and I'm going to pass to Faisel. If I had not gone into medicine, I learned health in 8th grade. And that's probably where most people get their health knowledge, from a gym coach for me in 8th grade. And then we start to have more and more information on the internet. It's confusing. I've gone to medical school, I've gone to residency, I've been practicing for over 20 years. Part of this is also a resource for patients in a constantly changing information environment, and what's true, what's not. It's constant. It's almost like medicine has become sensationalism too. It's fascinating. We need to take a step back. What is evidence-based, and really look at prevention. We spend a lot of money at the end of life rather than at those times, those pivotal transitional moments, that people can have a point where they can get a good quality life, extend 10, 15 years. That's why primary care, when you look at some real studies, have extended patients' lives. It extends their quality of life. So I gotta stop and let Faisel get on.
It's in America, we sacrifice when we're young, we sacrifice our health for wealth. And then when you retire, you spend all that money on your health, whatever you save. We don't have a culture of prevention, right? We have a very reactive culture when it regards our health, and we kind of push through. I think in general, if we look, I believe that we all lean in when we're talking about access to primary care as a moral obligation. But if you leaned in from the financial, let's go in with the dollars first. I think it'd be good for us to zoom out and just quickly give a snapshot of the financial situation of the American healthcare delivery system, at least prior to COVID. Prior to COVID, half of all medical care in the country was delivered in the emergency room setting at emergency room rates. Okay. And we know that majority of emergency room visits in the country are completely unnecessary, meaning that they could totally be managed in the outpatient setting. These are hemodynamically stable patients who don't have access to primary care. So when people don't have access to primary care, they'll go to the urgent cares and they'll go to the emergency rooms. And the hospitals know this. They have fast track in the emergency room. They have standalone emergency. Why do you think there's standalone emergency rooms popping up all over the country? It's because the majority of the people who go there are stable, but they can bill ER rates. So I tell the story about my pneumonia. 2 years ago, I had pneumonia. I went to a standalone emergency room here. Rusty, I don't know if I told you, my fever was bouncing between 104 and 106. My wife was threatening to call the ambulance. And I was like, no, we live in a small neighborhood. The last thing I wanted was for my neighbors to see me going out, going out like to the ambulance. But I said, no, drive me over there. I was there for a couple hours. I had Rocephin, azithromycin, normal saline, acetaminophen, Tylenol. What else was there? Oh, I had an EKG and a chest x-ray. And the hospital billed me for those couple hours $10,000. In the ending, our insurance paid $6,800 or $6,900. I took the bill to one of our center managers. We're full. ChenMed we only partner with insurance companies that'll give us full global risk. We take full risk, including the medications. So I took the bill to one of our center managers, and she said, okay, over here the azithromycin's like 40, 50 cents. The Rocephin's like 80 cents. The normal saline's like $1. Acetaminophen, the Tylenol is like not even a penny. She's like, yeah, this would cost us about $7 to treat in our centers. And that's what people don't realize. So let's zoom out even further. Let's talk about the total cost of healthcare delivery. Say we can't afford it. We can't afford it. Okay. We spend over $3.5 trillion right now for a population of over 330 million Americans, or about 330 million Americans, with the average American being 37 years old. When you think about the truly medically complex, people with not just one chronic medical condition, we're talking, like Rusty was talking about earlier, in our senior population, you're talking about 5, 6, 7 chronic medical conditions, all at the same time. You're thinking about people over the age of 65, right? And when you're talking about people over the age of 65, they only make up 15% of the population. And we're spending over $1 trillion just for 15% of the population. And one thing that has been very well documented and studied is the amount of unnecessary procedures in the country, unnecessary medical spend. Last year we crossed the $1 trillion mark. So out of 3.6 trillion, we spent over $1 trillion unnecessarily. And if you look at the 3 leading causes of medically unnecessary spend, yes, immediately before I came to ChenMed, I would think, well, unnecessary specialty referrals, right? Or overprescribing of brand name drugs. Yes, those are high causes of waste, but they're a distant number 2 and number 3. By far, the number 1 driver of waste in the country is unnecessary hospitalizations, which is fueled by emergency room visits, unnecessary emergency room visits. And so when you invest in primary care, suddenly, and how do you invest in primary care? You restore the doctor-patient relationship. When the trust is there in the doctor-patient relationship, suddenly the cost will go down dramatically. and patients will not be seeking emergency room visits. So then if you look at the country, you divide up out of 330 million people, we have now 30 million Americans who are uninsured. They're completely uninsured. They don't have insurance. Then you have like another 40 to 60 million Americans who are underinsured, meaning that they have insurance, but their copays and deductibles are so high, they don't bother using it anyway. But it's not. But then you have people who have insurance. I want to give a story about what happened with my aunt this last week. Dr. Dan, did I tell you about what happened with my aunt over the weekend? She gave me a call, having headaches and blurry vision and all that. Did I tell you about that story?
I think you mentioned it, but go ahead. Tell me again.
So she has insurance. So Rusty, my aunt has insurance. But she switched insurance. The first new patient visit with a primary care doctor is not until the second week of January. Okay, she has hypertension, and she takes a low dose hydrochlorothiazide, 12.5 milligram tablet. After Thanksgiving, she couldn't sleep. She was having headaches and blurry vision. Finally, she gave me a call over the weekend saying, look, I haven't been able to sleep. I'm dizzy. I've been having headaches. I've been taking Tylenol, and it's not doing anything. And I said, okay, well, I remember that she had hypertension vaguely. I was like, what's your blood pressure? Her blood pressure was like 170 something over 100. I mean, it was just out of control. She was having symptomatic hypertension. And the reason she called me was because she had a bloody nose. So you can imagine, I'm in a panic. I told her, double up, take another hydrochlorothiazide. Within a couple hours, she felt completely back to normal. Her blood pressure was down in the normal range. And in fact, I mean, the change happened because of Thanksgiving dinner, which we see all across the country with congestive heart failure. But thank God she got under control. That intervention I made with her only took a few minutes. And although now she still has to wait till January to see the doctor or to get established with a primary care doctor, those few minutes that I had with her, now her blood pressure is back to normal. She's actually very particular about her salt intake over the last couple of days. This has happened over the weekend. But that's what I'm trying to say. We avoided an unnecessary hospitalization.
Yeah, Faisel. So yes. There was an interesting question that came up, and that sort of fits in here is Zia asked, how do we begin to mitigate the gap of patient care the moment he or she leaves the doctor's office? And I mean, that's sort of what you're talking about. Your aunt's between doctors here, and she has a problem. Who does she call? And so, I mean, I would ask Rusty what his thoughts are about that.
Yeah, I mean, that's part of the issue is the warm handoff. If people are using the emergency room or urgent care as their primary source, they just keep going back there. So, and this is another rabbit hole, is there's obviously a shortage of physicians, especially primary care, because it's not really valued as much. But when you look at the data, we are the backbone that helps a society as far as healthcare goes. We have our specialists. We always need them. I appreciate our colleagues. But we really need to invest in primary care because it needs to be that warm handoff from if they go to the emergency room, they've got to follow up with their primary care physician. And that's one of the other issues. If you can't get in to see your doctor, there's a problem, you know? And so it has to be a warm handoff. And then the other problem with communication, a lot of people are on EHRs, but the interoperability, they don't always talk to each other. So and we're relying on patients to give us the history. Hopefully they can get the medical records, but there needs to be, that's a great question. And there needs to be a warm handoff from the physician to a primary care physician, from the ER to the PCP, so we can follow up on the blood pressure before it turns into a heart attack, before it turns into a stroke. These are all warning signs for something worse. The other crazy thing is when you look at the cost, 5% of the population can consume 50% of healthcare resources. And yet, why are we still having this conversation where we need to have, it seems, when there's emotional thinking and logical, and I realize there's only so much of a pie, but when we are when you look at this logically and from a business perspective, Faisel and Robert's point, is the return on investment is fund your physicians to follow up with your patients. When you look at countries that have regular follow-ups with their physicians, not over treatment, not over, not this drug-driven or over-treatment society that sometimes we can become. It is evidence-based. If you follow up this high touch, creating this relationship where, like your aunt, our patients call us, my blood pressure's up. we have averted a hospitalization and also a complication that could either kill them or be life-changing.
Right. And so, I think what's really important here is that you have to have high quality primary care. You also have to invest in it from a high level. So you have to have primary care that builds that relationship, that's incentivized to build that relationship, that might connect with patients if they can't come into the clinic via telehealth or, via those engagement tools that might keep patients actually like communicating with their care teams. And at the same time, though, the society, which is, going back to sort of the larger topic here, has to decide that this is something that we value. And communicating the idea of what you two just described, that there is the ability to avoid costly hospitalizations in emergency departments. And I always say this, I said this in my book, I was like, nobody goes there because they want to. Like, they're going there because they're very sick. Or they're going there because they don't have anywhere else to go. And so the very simple solution here is to incentivize the primary care physicians to be able to connect with patients in a better way. You guys do that very well at ChenMed because you have smaller patient panels, you can spend more time with patients, and you've built this model really nicely. But it also means maybe increasing the supply of primary care physicians by funding more residency programs or increasing reimbursement to attract more physicians to that field. It also might be, making sure that everybody is covered for primary care as a baseline across the country with their health insurance coverage, either public or private, which is what the Affordable Care Act was trying to do. Unfortunately, there were some people that were caught in the gap when some states chose not to expand Medicaid. And so we have a lot of people that end up in really high cost situations that don't have access to high quality primary care, or they have access to primary care that's not of high quality. And then we don't prevent these costly episodes of care. And it is this cycle, Dr. Harrington, you said perfectly. I mean, it's a cycle of us having these conversations. And I think why we're having this topic right now is we want to try and convince people that we don't care about the politics. This is what needs to happen for health. And it's well established, and it's extremely, extremely evidence-based that primary care saves money and it produces better health. And that's what we all want at the end of the day from our healthcare system.
Yeah. I honestly, as a physician and a consumer, I want my money's worth. Who can argue with that? And so this is where we really need to just have an honest conversation about, are we getting our money's worth, and how do we? And that's part of medicine has become a tradition, and there is money in it. It's $1 trillion. But if we can invest wisely, that, $100 million at that pivotal prevention side, one thing I've learned, especially in Faisel and everybody, people don't like to suffer. So why do they engage in something that's going to make them suffer, or not do the things that are going to help alleviate or prevent it? When we break that down, then it's a matter of why. Do we not have access? Do we not understand? Then let's break it down and figure this out together. Because I want lower rates. I want to be healthier. I think most people do. And I don't want it to be on anybody else's shoulders. Yeah. My health is my responsibility, but also we are still paying for other people. So let's be smart in how we spend it.
Exactly. We're already paying for it. When anyone says that, well, the government shouldn't have to take on this risk. I hate to be the one to break the news to you, but with programs like Medicare is already straight Medicare. 80% of the risk is with the government, 20% is with the patient. And then with Medicare Advantage, of course, all the risk gets transferred over to the private insurance companies. And of course, companies like ChenMed only make partnerships with insurance companies that'll give us the full global risk contracts. And then we take on the risk. But then what happens when we take on the risk? Is it a patient-centered model? It's absolutely not a patient-centered model. It is absolutely not a patient-centered model. Our healthcare delivery system, the doctor is at the center of the delivery system with support for the doctor so that the doctor is focused on being a doctor. And people that always kind of raises eyebrows, so patients come second at ChenMed, and what good are we to the patients if we don't take care of our doctors first? I think it's something, Robert, you were saying in the last couple of weeks that half of American doctors are experiencing some degree of burnout, and 2/3 or 70% of them aren't even recommending their children to pursue a career in medicine. because
Right.
they just don't feel fulfilled. I'm not surprised because 95% of American healthcare is fee for service. It's transactional. It's not the world that we're in. Probably, I think the only people who are in the similar world as Rusty and I are who can feel similarly are the ones who are in the direct primary care world. Like the direct primary care doctors aren't concerned about this transactional, the transactional nature of just the encounters in the fee for service world. We aren't either. We're in 10 states. We're going into Texas in the next couple months. And Robert, I don't know if I told you this, but in 2021, we're going to Michigan. We're very excited, very exciting, very exciting.
I saw that you go to DC. I'm telling you, there's a good spot over there. There's the right place for you guys.
It's not a question of if, it's just when.
Gotcha. So
But we don't have a billing department. We don't have a billing department, and our doctors are not concerned with billing, and that's what's burning out American doctors. American doctors are spending like 15 minutes per patient encounter just documenting the visit because they're concerned about billing and reimbursement rather than they're actually more concerned about the medical complexity of the documentation than they are with the medical complexity of the patient sitting in front of them.
Right.
And if you think about it, from medical school and residency, we've been programmed to think in lines of the chief complaint. Everything in the documentation, it's a reactive way of documenting as well. What is the patient's chief complaint? And the hospital systems have completely capitalized on that because they're like, you've got a patient with COPD in between COPD exacerbations, and they're there to see their doctor for low back pain. The doctor spends the entire visit addressing the low back pain. Okay, we'll see you back again next time. Meanwhile, you have a patient with COPD who's in between exacerbations. That wasn't addressed. That patient's still going to the emergency room for the COPD.
Right.
Whereas in our world, rather than focusing on it, we tell the patients, okay, this is your chief complaint, but now let me, as your primary, I'll address your chief complaint. That's my minute clinic visit. But now let me talk with you about my primary concern as your doctor. And I think that's where the shift needs to happen. Where you invest in primary care. Because right now, out of 1 million doctors in America, only 200,000 of them are primary care doctors. 800,000 are specialists.
I was going to say, Faisel, I mean, this is a huge problem. And that we have, this is part of like, you have the quality of primary care systems, and then you have the actually giving people access and funding those primary care systems. And what you're talking about is a perfect reason why, we have some people who have access to primary care, but a lot of times it's not very effective. And that comes down to universal healthcare as well as both improving the success and the quality of what people are getting, as well as just improving people's access to having that healthcare coverage service. So with that in mind, what do you want to leave people with? What's your last soundbite, for people who are watching, as we get ready to close out here? What would you say, Dr. Harrington? I'll let you go first, and then Faisel, you can take us out. What is the takeaway here?
I mean, it truly is the shift, as Faisel is talking about. It's a shift from volume of care and the speed of just seeing as many patients as we can, just patient. It is the quality of that care. So at ChenMed, I'm actually measured on the quality of my care, and I take pride in that. My patients have more quality days, and being able to measure that and not just the cost of my care. Cost matters, but it's the quality of that, and it's the life-changing that it brings. That for people, this can be life-changing. And not only we're dealing with an individual, now we're dealing with population health. We need to shift from a volume of care to a quality of care, and not just the pay for performance of fee for service. It is a true shift. Free yourself up so a doctor can be a doctor. You always worry about the care. What happens to the caregiver? They may die first because they're not taking care of themselves. Let the team take care of themselves. Focus on wellness. It spills over to the happiness and the well-being of our patients. Thank you, Faisel.
Oh, Rusty, thank you so much for joining us tonight. I think when you said earlier, most of us got into medicine to help people. But when the healthcare system forces us to be more concerned with billing, where's the purpose in that? And I think that's what we're facing right now with healthcare delivery in the country today. I mean, if you think about a doctor at retirement, there's no doctor who looks back on their career saying, hey, I felt really fulfilled reliving my billing history. And I think what we need to do is, when we focus on prevention, and we didn't even talk about early intervention or efficient intervention. I think that once we see all the time, like, for example, how many times, Rusty, have you seen a diabetic patient who was started on insulin 20 years ago with a hyperglycemic episode in the emergency room, and then over 20 years they've just been refilled the insulin over and over and over again? Then you get to see them, you talk with them about lifestyle, and you realize that they were never even tried on oral meds before, or nobody educated them on the proper diet. You get them off of insulin in a couple months, and they think you're God's gift to medicine. But but that's what happens. When you're dealing with, especially the medically complex patient population like we are, we actually, all our centers are located in the most vulnerable neighborhoods across the country. Really, I think that when I think of where a community health center is, we're in the same neighborhoods as the federally qualified health centers. Except, with the federally qualified health centers, that was my background. Our average patient was 38 years old. At ChenMed now, with the Medicare Advantage population, our average patient is 72 years old. So I feel like our population is very complex and probably much more needier of a population. So my takeaway point for everyone that I'd like for you to go home with, go to bed tonight with, is that, hey, we're already paying far too much for healthcare. It's not a matter of us being able to afford it or not. We're already paying too much for care that's not delivering the right kinds of outcomes.
Let's just take some of those dollars that we're spending and let's distribute them to people who don't have access to primary care, and let's bolster that primary care service. And we're not going to spend more. We're going to invest in things that produce return on investment. So I think that's a great topic.
Well, I'd like to thank Dr. Dan. Do you have any closing thoughts before we close out for the evening?
No, I just echo everything you all are saying. It's time to make a change, and it's time to give society what they're paying for, and not be robbing everybody to do unnecessary care.
Well, Rusty, thank you so much for joining us. I look forward to coming back again. I guess we're going to be doing this on Thursday evenings at 8:00. To our audience and who took time out of their evenings to join us this evening, we're trying to get tighter. We're trying to get to like 20, 30 minutes. We found that over the lunch hour, we were going almost an hour. Thank you for joining us. For more information about today's topic and to explore career opportunities with ChenMed, please visit chenmed.com. I believe that access to primary care is a right, not a privilege.